Yongjin from the Ilsan Apson Dental Clinic. We looked at the overview of digital guided surgery system, and also I introduced OneGuide system. And lastly, we looked how the OneGuide kit can be used in the last sessions. For the next 3 sessions, I'm going to tell you in which cases this OneGuide system can really be applied. First, be it OneGuide or digital guided surgery, I think the easiest case to use is for the anterior implant placement. So first, why do you need to use guided surgery system for the anterior part? As you know, on the upper anterior part, if you position the implant in the wrong position or the angle is wrong, then it could lead to these disaster results. So it's really tricky to place anterior part implant. And it's aesthetic area. So if you place the implant wrong compared to bridge or the conventional method, it can become less aesthetic. You know all this part very well, so I will skip that. Then, why in the anterior part do you need to use digital guided implant surgery system? There are 3 reasons. First, after extraction, inevitably there is a bone resorption, but with this system, such resorption can be minimized. The thin labial bone will be resorbed after extraction, so you have to carefully take the tooth out. But the recommendation, because of that, is also to go flapless surgery. But if you can do guided surgery, then you can minimize bone resorption. And secondly, you can simplify bone grafting procedure. Now, because you can control the gap size, graft material can easily put into that gap hole. And thirdly, provisionals will be created beforehand and delivered immediately, making it more aesthetic. Let's look at one such case. On the upper part, 6 teeth were extracted, 3 implants were placed. But due to periodontal disease, there were mobility, and also on the right upper side, prostheses were also kind of shaky. This is pre-surgery photo. Gingival recession or labia bone defect did not exist, so I planned for immediate implant placement. To use OneGuide system in the Implant Studio program, first, ideal crown arrangement was done, so prosthesis design was done first. This is top-down approach, as I explained before. On the occlusal plane, this is the arrangement. And based on that, to place implant in the ideal position, ideal prostheses were designed, and to support that, on the CT image, implants were planned for ideal positioning. So 3 implants were planned on the both side, number 3, and on one side, number 21, where the implant will go in. And OneGuide template was designed for adequate and accurate drilling and procedures. And after extraction on the day of surgery, the template was delivered, and then we saw whether there is gap between the teeth and the template, and if it fit well. And if it fit well, then you go for drilling based on the diameters that you all planned. And before that, OneFit, the CAD/CAM abutment by Ostem, was also something I had ordered. So I not only ordered the guide, but I wanted to deliver CAD/CAM abutment immediately after surgery. So I even asked for prefabrication of this CAD/CAM abutment that's customized to the patient. So if everything was placed correctly, then CAD/CAM abutment that was prefabricated will also go in the right place. So I put 3-1, and even the PMA type bridge was prefabricated, and I delivered. Of course, socket preservation and graft material in the gap area were fully packed. Now, after surgery, this is panorama photo, and this is PA after surgery. As you can see, prefabricated abutments are placed very well. Now, without opening flap, using the abutment and temporary that you prefabricated were used, then you can have excellent gingiva feeling and patient will feel less uncomfortable. This is 8 weeks post-op. You see on the upper side, there's a TMA bridge. It's not the final prosthesis, but it's still very aesthetic, and papilla recession does not exist, and labial gingiva recession also do not exist. This is 12 weeks post-op. To deliver final prosthesis, temporaries or provisionals were removed, and as you can see, adequate pontic base is used, and for gingiva molding, then the papillas can be really created very well. And I delivered the final prosthesis, and this is photo taken afterwards. And to place the implant, I did not use a blade or did not do any suturing because flap was not open, and that is the strength of the guided system surgery. This is after delivering final prosthesis. Now, I'm following up to 2 years, and as you can see, there's no gingival recession. Of course, gingiva biotype of this patient was thick, but even for a thin biotype, this guided, I think surgery is very much needed. No problem exists for this patient. The aesthetics are very good. Patient is also very satisfied. Now, on the upper anterior part, I showed you how the OneGuide system can be used. On the lower anterior part is also a challenging area to place implant there. There are a lot of issues. The biggest issues would be first, there is a narrow bone width, and secondly, narrow mesiodistal distance. In other words, tricky to drill and to place implant. The bone is thin, so you need to do grafting. So a lot of tricky issues. So the mandibular anterior area, some hesitate or do not want to place implants. And anatomical condition shows that there is narrow interdental space, and mesiodistal distance is also very narrow. And because of that, typically, if you want to place a typical two-piece implant, then you have to do block bone graft or smart builder or os builder, and other customized titanium mesh needs to be used for GBR. So it's really complicated. Another thing is that even if the bone width is narrow and measure distance, distal distance is adequate, you can come across like this case. So if you place implant, measure distal distance is narrow, so mount type two-piece implant, if it's placed, then mount driver can get jammed. So I want to place implant in the good size, but there's a tilting to the buccal and labial side. But there is one strength. Unlike the upper part on the mandibular side, the strength is with the bone quality. It's either D1 or D2. In most cases, it's that level. So initial stability can be easily secured. And because of that, on the lower anterior part, to overcome the challenges, MS implant was designed by Austin. So I prefer using MS implant on the anterior part on the lower side, especially for the lateral incisor and central incisor. And I don't really use MS implant for canine part. And this is the MS implant. This is one body type, very sharp, and it has tapered body, and you can increase initial stability. And because it's one body, placing abutment or linking impression coping, such stems can be simplified. And because of that, in the narrow bone width, and even in those cases, MS implant is very narrow in a width, so you can place them there. And measure distal distance, even if it's narrow, you can use MS implant. So for single missing case on the lower anterior part, this is very good system. And even for multiple missing cases, I think it can work very well. So let's talk about MS implant case. It's where number 32 has been fractured while eating. And on PA side, you can see the fractured line. and there is a fracture, and the crowns that was moving was removed and root rest remade. So you can use two-piece type implant, but after that, on top of that, the abutment on the cervical side, the diameter is more than 4.0. So for the adjacent natural teeth, the mesial-distal distance, with that there's no much of interoperability, and it will be very much detectable. But for MS implant, its diameter is 2.0, 2.5, and 3. So the abutment part is very slim. Hence, after making final prosthesis with the natural adjacent teeth and the cervical side, it will be very much well matching. And that's why for this patient, I went with MS implant. I carefully extracted and used periotum atraumatic extraction, and then use this implant where the gingival height was 4.0. So again, this is MS implant. Initial stability was okay, about 30 newtons. And this is the photos. So as you can see, after placing MS implant, this is one body implant, so provisional cap. The temporary crown is cemented with the provisional cap, and on top of that, temporary crown is cemented. In other words, the abutment area of MS implant, you don't directly cement to that. So like clip-on type prosthesis, temporary prosthesis can be made. Like this, clip-on type provisionals are made and delivered. After gingiva, you wait for gingiva healing and osseointegration. After 2 weeks, this is how it's healed. And if to do GB up, you open the flap, then papilla would have reset, and there could have been scars, and it would have been not very aesthetics. But in such cases, we went with the flapless approach, and immediately temporary crown was delivered. So it's molded to gingiva, and the papilla of the adjacent teeth were maintained. After 6 weeks of surgery, osseointegration complete, so I took impression. In taking impressions, the plastic impression cap is clip-on type, so very simple impression taking, and the final prostheses were delivered. And as you can see, what is implant versus what is natural teeth, you cannot distinguish. So these are the strengths of the MS implant. Post-surgery, after delivering final prosthesis, PA. 24 weeks later, you see there is a good maintenance, and this is PA. And as you can see, around one body implant, this is how the bone looks. There's not much of marginal bone loss. It's well maintained. So on the lower anterior side, in case of single missing, diameter, if the thick implant, you had to do GBR block bone grafting, but by using MS implant, such procedures can be eliminated and implant placement can become very simple. But still, MS implant is very much dependent on the surgeon's experience. One body implant, so abutment, bending depth area, or in two-piece type abutment, the angle, compensation or correction is not possible. So in this implant, mesial-distal buccolingual position and angulation needs all to be correct. So labial surface line with the adjacent teeth, you have to go a bit toward lingual side. So it's very dependent on your experience. So if you're not experienced in implant placement, it might not be the first implant system you would go for. Then, using OneGuide kit, you might think is possible, but if you look at OneGuide kit, OneGuide drill stopper diameter is 6.0. But as you can see in the photo, in the mesial-distal distance, if it's less than 6, what to do? You cannot use OneGuide kit because OneGuide drill to drill in full depth, mesial-distal distance needs to be at least 6.0. But in single missing, that would not be possible. What to do? So Austin created to overcome this narrow ridge. In case distal distance is narrow, to enable distal guided surgery, we developed new kit. It's OneMS Kit. It was named One Narrow Kit, but now it's called OneMS Kit. So on the lower anterior side, mesodistal distance narrow, or if you want to place one body implant, then using this OneMS system would be the good option. So let me explain about this OneMS Kit. In OneMS Kit, the implant you can place is MS implant, narrow ridge type, denture type, and temporary type. So 3 MS implant can be placed, and recently Austin introduced TS3 two-piece type 3.0 implant, the most narrow two-piece implant. This can also be placed using the OneMS Kit. Now, on the lower anterior side, where the mesodistal distance is narrow, we reduce the guide barrel diameter to 3.5. In OneGuide kit, guide barrel diameter for normal hole drilling 5.0 and wide hole was 5.7. But here, it's 3.5. This is because mesodistal distance is often very narrow. And to avoid interference from the adjacent teeth, offset was extended. So guide barrel has become longer. In the OneGuide drill, guide barrel length was 8.0, but it's now extended to 11 millimeters because the offset is longer. In the OneGuide system, offset was 10.5. Offset is from the top of the implant to the top of the generated guided hole, that distance. So for TS implant, if you place with the OneGuide system, the distance is 10.5. But with this OneMS system, it's extended to 13.5, and guide barrel length has also been extended. This is to avoid interference with adjacent teeth. So on the lower anterior part, gingival recession or vertical bone resorption often happens, and the crown becomes longer. In such cases, guide barrel drill is extended, and offset is also extended to avoid interference. And also, the library itself for MS implant and 3.0 TS3 implant are in the implant studio. So also in the OneMS system. So guide hole can be matched in the planning. So you don't really have to worry much. Just to the digital center, say I'm going to use OneMS implant here, then you would see that guide template for this OneMS kit will be made and delivered to you. So this is how the kit looks like, and everything is very narrow in diameters. Flattening the others are same as in the OneGuide kit, and implant drivers and drills are included. Now, in case of tissue punch, on the lower anterior side, gingiva is thin, so you don't often use it. But if you need it, then you can use this tissue punch. And flattening drill, the sharply remaining bone or irregular crestical cortical bone or to flatten them, flattening drill can be used. And I explained about this in the OneGuide kit. And OneMS drill, in MS implant or two-piece type 3.0 implant, this will be used as the final drill. And MS drill looks like this. Length is 8.5 to 13 millimeters. And in OneGuide kit, the shortest was 7.0. And you have to buy extra for 6.0. But here, it's from 8.5. And also, on the lower part, if you have D1 bone, then if you have too excessive torque, then compression necrosis or bone heating could be the result. So the cortical drill can be used to overcome such challenges. And to place implant, you have drivers, narrow ridge type. MS implant can be used with this driver, and other types of implant can be used with this matching drivers. Now, MS implant narrow ridge type is one body type, and gingiva height, there are two variants, 2.5 and 4.0. So the planned implant gingiva height will determine the depth that you need to go into. So for MS, you have a dedicated fixture driver, and there is a thick line, and top and bottom part of the line, the gap is 1.5 millimeters. So gingiva height is 2.5 of your implant. The guide hole top needs to go to the top of this line. That's how you control depth. If the gingiva height is 4.0 of your implant, then the guide type needs to be matching to the bottom of this line. Now, how to use it? MS implant has a sharp apical area. It looks as if it's bone screw. So you don't have to do full depth drilling. It sort of self-penetrates. And initial stability is designed to be strong. So based on the surgeon's experience, you drill and place the implant. But one thing you need to remember here is that on the lower anterior part, long implant is something you would place, and 11.5 or 13 millimeter implant, in placing even those implants, in using OneMS drill, you have to start with the short drill, because if you start with the long drills, then the guide hole's length and the drill length, if it's not matches, if the drill is longer, then guide hole or guide barrel's initial contact would not be possible. So guide hole cannot guide the drill. So in other words, in the same diameter, 8.5, use that as initial drill, then extend the length. In the OneGuide kit, diameter were extended. You use initial drill and then F3.5, 4.0, 4.5. So you increased diameter, but in OneMS kit, not diameter, but length will be increased, because 1.5 or 1.8 drill and place in 1.5 diameter MS implant is how you go. So you don't have to increase diameter, you just increase the length. And the bone quality here is good. So there could be limit in irrigation if you do two long ones. And because of these irrigation issues, carefully, sequentially, you increase the size. And guide contact would happen with 8.5, so you start with that. And then 11.5 or 13 drill needs to be used for double contact concept. So this is the drilling sequence. In most cases, the implant that I want to place, minus 0.7 should be the final drill that you use. So for 2.5, it's 1.8, 3.0, you use this type of drill. This is when the bone quality is normal, but on the lower anterior side, D1 or D2 are typical bone quality, so normal drilling procedures is something that you could use. Then, once you build experience, then you might think without guide you can place OneMS implant. But there are cases where you need to guide. If such patient came to you and said, I want implant, then what would you do? Could say, recommend bridge because implant is not possible. But with MS, you can place implant. But even in these cases, without using guide, placing MS implant is not something I would go for. So let me show you one case. 21-year-old female. So on the canine side, there's a missing tooth, so did orthodontic treatment and secured some space. So came to me to have implant. And as you can see this, the MS implants, you can say I could just place that, but the mesial-distal distance might be okay, but buccolingual side, because there is a missing tooth, so it was very thin. So this is the front photo, and hence I place MS implant and decide to use OneMS system kit. So I took photos, took the scan, and sent to the digital center, and received this template from the center, placed in the mouth, placed implant. 2 implant flapless. So it went according to plan. I had initial stability that was good. This after photo. And one more thing, as I said, when you order to digital center, you could also order temporaries. So the temporary crown that was prefabricated was set. This is post-op panorama photo, PA, and as you can see, mesial-distal distance was very limited, but the implant was placed okay. If it have you a lot of experience in such case, just open the gingiva and placing implant, could that be the result? You would have to take X-ray and other very complicated steps would have been required. As you can see, the bone width was very narrow, but you can see it went very well. And this is 4 weeks post-op, not much of a problem. The integration is happening very smoothly. This is 3 months post-op. When I delivered the final prosthesis, the gingiva is healing very well. I did not open flap. The papilla is also maintained very well. I took impression. And then final prosthesis was delivered. And even after that, what is implant, what is natural teeth cannot be distinguished. So it's very aesthetic. If the MS implant was placed without any support, it could have gone okay, but it might have also not been very aesthetic. So looking at these cases, again, top-down approach is very important. Design the final crown and place implant in the ideal area. If it's 2-piece type, using abutment, some correction compensation can be made. But for one body MS implant, the help from guide is very crucial. So after final restoration, panorama picture and PA picture, without much of a bone resorption, you can see it's healing nicely. So I showed you on the upper and lower anterior part how to do guide surgery with actual cases, and we looked at OneMS Kit and how to treat single missing case on the lower anterior side, how implant can be placed easily. So when placing MS implant, what should be the initial stability is the question I was often asked. Same STS type implant, 30 to 40 newtons would be sufficient for immediate loading. So on the lower anterior part, placing MS implant, you don't have to worry about initial stability too much because bone quality there is good. And if I may share with you my own tip, then diameter, I just drill up to the guided line. So 2.5 implant, then up to 1.8, I do the drilling. So using the depth, I control initial stability. So 10 millimeter MS implant, then drilling depth will be about 8.5, and using 1.5 remaining, I try to secure initial stability. After placing MS implant, it is because usually you have to do immediate loading. Next, how do you deliver temporaries or provisionals? Now, in the first case of the MS implant, provisional cap was placed on the abutment, and on top of this, there was cementation. But in the Austin Digital Center, if you tell them to use OneMS system, then temporary will come that fit to your abutment. So it might be a new step, because after placement, putting temporary cap, on top of that prefabricated, if you want to put provisional, then it doesn't fit, because there is no temporary cap library, only library for abutment. So using OneMS system, placing OneMS implant, then provisional cap, the temporary plastic cap will not have to be used. You can just cement to the abutment. That is the difference. So I hope that you will not get confused about this. Now, up to now, I looked at how to use the digital guide surgery system on the anterior part, and I will see you at the next session. Thank you.